GI, which you're in now, emergency medicine, pediatrics, nutrition, infectious disease, and then your capstone is that very last thing. So that's 5 more to go. You will enjoy physiology during GI, nutrition, and infectious disease. So you have about 40 more physiology questions to go. Nutrition is a big, there's 4 hours, 16 questions of nutrition, and that's a great place to kind of get some points. And not just in, this part, but I think nutrition is so well placed. You can do it early in the year and have great success with it. But I think something about putting it at the end of the year and tying that patient, normal function, nutrition with all the crap you've learned is just it's a nice time to put it, I think. So it becomes a good bookend, I think. And then, gosh, it's just getting better. You're getting there. I've walked in several times anxious. Today I'm probably at my peak anxiety and just a terrible state today. I have this chronic relapsing remitting kind of depression, and I just sunk this weekend. I don't know if it sounds familiar at all to you. It doesn't take hardly anything. We're in a great time of our lives. Our house isn't underwater. We have healthy kids, but we're stressed out, and then one of our kids isn't talking to us. And I mean, we just moved as a couple. I mean, we both just sunk, and when he sunk, I sunk, and we just sunk. Well, what would happen ordinarily, I recognize it, oh yeah, I'm depression, and you want to die. And so then I would just kind of stay in and have like psychomotor retardation for a couple of days. I mean, that's just no way I would deal with it. But since I had to come teach, then I get super hyper SNS. So my heart rate is very high, my respirations are rapid, not very deep, so I can't catch my breath. I get this dysphonia from just sort of constriction. My stomach's a freaking mess, which is kind of my reaction to all things. Some people get headaches, some people get sick stomachs, whatever. So anyway, with that comes kind of short-term memory loss and word-finding problems. These are things I recognize in myself. So if I was taking you on a hike, I would say, oh, my knee is acting up today because I have arthritis in it. I'm going to baby it. We're going to go a little slower. And you would go, yeah, okay. And so if I walk in and have psychological pain, it's just as real, and if not, affecting me worse. And so I think it's fair in this setting, because you guys are going to be treating patients, is that I tell you that symptom and you kind of recognize that as such. And anyway, it sort of diffuses it a little bit, because I don't, that voice that would go, you're such a liar, you're such a fake back there. Does anybody recognize that at all? Like you're functioning and your body's walking and talking, you're sort of robotically going through. There's some great ad for a antidepressant that the people are sitting there and they have masks over their face, like a happy face mask. And I really get that. But I could be doing that, and then there's this voice behind me going, you're such a fake, you're so unworthy, you're so dumb. You see, you can't remember that word. And so anyway, if I just come out and admit it, that doesn't get so big. So anyway, I am terrible today. I mean, I'm just terrible today. I'm so ill psychically. So anyway, that's just not abnormal. And it's, sadly, I will just say that you thought people like me, my age, were probably that figured shit out. I'm just saying to you, you're not going to figure shit out. There's no other side of this where everything's better. So I just encourage you to every day just go, this is an ordinary day, and I thank you, God, for it. You know what I mean? When I do that, I remember it. And this idea that, okay, things are just crappy because I'm in PA school or because I'm not married. I think I've said this to you before, or this or that, or, when I get my hair grown back out, or when I get my hair cut, or when I stop. It's all going to be better on the other side, and I just think that's just a terrible way to deny yourself the good moments, because I've done that too. Anyway, I just say that. And then also be nice to your folks. If you have people who raised you, you think they're fine, and you can just be mean to them and take stuff out on them, and they are fine. They can't handle that. But understand they're still vulnerable too, and it actually gets worse as they age. So. just a little aside. Keep that in mind. But anyway. So, with that, bear with me and tell me the words I'm searching for. They're often very easy. Okay, Andrew, which rotation are you looking forward to?
Neuro.
Like neurology?
Yes.
Oh. Does that mean you're a good listener?
I'm good at it.
Well, I mean, your neurology patients, it's really about that history, I think. So you're going to listen a lot, and then of course your test will be very specific. But I mean, you have to hear a lot of things, I think, from neurology patients. So that'll be a good thing if you are a good listener as well. All of us need to be, right? Randy, is it Toyne?
Yeah, Toyne.
Toyne. And which one are you looking forward to?
I'm not sure. Maybe, I think like peds. I've never really worked with kids before. Kids scare me sometimes because I'm the baby, and so anytime I've ever dealt with kids, they've been like nieces and nephews, so it'll be nice to see. Kids like me when I'm like hanging out with them because I look young, so maybe if I'm like doing a peds rotation, I don't know.
See, I don't like children. Really not even mine. No, I get it. There's more sort of diagnostics in it because they're not going to be able to tell you this detailed history. Okay, well, all right. So, like in March of 12, I felt a little numbness on my right lower foot. They're not going to start there, and you're going, okay, let me just hold up. I'm going to vote now. But yeah, there's a little diagnostics I think that's good there. I think for me, it's not kids; it's really parents.
But then I can keep like candy in my white coat, and then I can snack on it when I'm not eating. And also like, oh, you have a boo-boo like here.
Self-medicate. That's right. That's right. Starburst. My car right now. Interesting. Okay, everybody. There's a lid for every pot. And sometimes there's just pot. LOL, so true. Open cabinets and fridge, find nothing to eat, lower standards. And it also works with the remote. Like you go through and go, yeah, maybe that side field looks fine now. So anyways, GI, oh my goodness, you're gonna run into guts all the time. The functions of the gastro. See, this is awesome. You already know a ton about the GI tract, and so these things are getting more redundant and easier. So the things we know we ingest, and we have to propel stuff through. Mechanical digestion, chemical digestion, hormone secretion, absorption. That's the whole point of eating, is absorbing the nutrients into the bloodstream, and then elimination of the stuff that doesn't get absorbed and or digested. So we know when all of that is going well, people are happy. If you ask people about their diet, they will trust you. I find this to be so true. And if you take care of their very special, the most basic functions, like, are you sleeping? Are you eating? Are you pooping? These are just, people just like go, you just see them like, okay, they're gonna listen to me. And so that's so big, and I know especially with the hospitalized patient, which is what I worked with, is that if they're not home, and if you're meeting those needs that are so tight to us, or what we eat, then they're gonna feel better about their hospital stay, and they're gonna feel better when you walk in, and they're gonna be, their treatments are going to work better, and all of that. So always remember, like I've said to you, are you eating high quality protein? Are you staying hydrated? Are you resting yourself? Take care of these real basic things. And that is, of course, when you're not in an emergent situation, when someone's actively bleeding or something, then don't worry about that. But for the most part, you just need to make sure, and that gives you an indication. Well, if you're eating and you're pooping, at least that system's kind of working. And if you're not eating more, you haven't changed your diet a lot or whatever, then we know that kind of state. What shape you're in there. So I think it's a great place to start. So the wall histology, the layers, we always start there. It's a tube. A professor told me 100 years ago that we're a donut. So you're open from mouth to anus. And so we think of this as just a tube. And this is why we feel very differently about the mouth than we do the anus, but we're real interested in both of them. And you get way more interested in one as you get older. And so, oh, and I will also tell you, since my husband came last time, I do his toenails, I give him a pedicure. That's the kind of wife I am, because I don't want to look at his toes without me doing it. Sorry, I know you're eating. It's not going to get any grosser than that. But he'll just go, he thinks once across there's enough, and the toe is, no, this will ruin my sheets. So I do his toenails, and he's a big, huge baby about it. And now he says, oh, you're hurting my matrix. And I'm like, God, wife, that's my matrix you're digging in. It's so pleasant to have him here last time. Information is dangerous. Look at the lovely mesentery just kind of wrapping around, suspending the whole thing. Love that. But from the innermost to the out, we have the mucosa, submucosa, the muscularis layer, the serosa. And then outside of that, you would have the mesentery. And we'll just look at each of the layers there. So all along, for every organ system along the way, we look at each of these things. Oh, that's as far as I'm going here? Okay, we'll go further as we go along here then. So starting off with the oral cavity, spending very little time here because you should have mentioned teeth and ENT and that sort of thing. But salivary glands are really part of the whole oral cavity health for sure, and eating. So kind of the biggies: parotid, overlying the masseter, the submandibular and sublingual salivary glands. And then you also have buccal glands, which are just sort of intrinsic glands that are scattered throughout that mucosa of the oral surface. When we don't have saliva, it's a very miserable life. So when you have people that have had irradiation to the from ENT cancers and such, and they've had irradiation and they've lost salivary gland function, life is very tough without salivary gland. So it certainly goes to your oral health in general. But when digestion, we think about it, lubricating the food that you're eating and masticating and trying to form it into a ball or bolus for swallowing. And so super important in eating, tasting, just whole health of the mouth, oral cavity. So here are some of the components: saliva, clean and moisturize the oral cavity, moisten food for compaction, allowing for taste. And we begin the breakdown of carbohydrates right here, so you can start sugar absorption really quickly as soon as you begin to have sugar enter the mouth. So sugar itself, glucose itself as a subunit, will be able to enter mucosal surface cells right away. Carbohydrates, or chains of glucoses, would have to be broken down, and amylase begins that process. And so saliva has amylase as part of it. And here's just sort of a list of stuff in there and what it does, but water, mucus, some antibacterial sort of things. Where is that on there? Lysozyme, which is you have like in tears, lactoferrin, lactoperoxidases, IgA, the secretory form of immunoglobulin, will be in saliva. So antibacterial quality. It's a little bit alkaline, so some neutralization of acids in the mouth and so forth. And so that's really it. We like our saliva. I like it better when it's in your mouth than on the sidewalk, but you got your spitters. You have your spitters. The salivary glands themselves, what cells are there? A couple of big cell classes, and there are serous cells, which are really creating a lot of the watery portion of that will contain electrolytes and enzymes and such. And then the mucus cells, which will be secreting mucin, which is a glycoprotein that bulks with water and kind of creates that mucoid, or creates kind of mucoid, it creates mucus. And so that helps with the lubrication and that kind of forming that barrier or layer that you get that good smearing with the waters and saliva. So again, I'll just remind you that mucus is an adjective, and so the noun would be M-U-C-U-S, mucus cells is O-U-S, just so when you're writing notes, you spell that right. So why do we salivate? a lot of reasons. There are higher level thoughts, there are Pavlovian responses. You see those, those Brahms commercials every day. Come on, at that time every night, that time for chocolate every night. And it's super sexy with the fudge. That fudge is drizzling all over the ice cream. And you kind of like go, someone eating that hamburger and it's sloppy and drippy. Maybe that's a turnoff for you. Just shouldn't be saying that out loud, but it's, you begin to think about and you prepare. And so that's part of the salivary response. You have chemoreceptors and stretch receptors, mechanoreceptors, that once food is once food arrives in the mouth, then you also have salivation as part of that. And so, we have a tone of salivation throughout the day, regardless of food or outside of food. And clearing secretions becomes a really big part of handling patients. And so you have patients who are at risk for aspiration, are those with dysphagia or in some slight inability to great inability to swallow, extremely common, and especially in the aging population. And just clearing secretions becomes very difficult. We think about swallowing problems with eating solids or swallowing thin liquids, which is actually a bit harder to do well. And so then salivation becomes part of that. And so, and then the side effects of certain medications which cause dry mouth. So all of those things, you will really be seeing shockingly more of it than you would have suspected in terms of just salivation and clearing secretions or appropriately making them. So how we create secretion from those glands is via facial and glossopharyngeal nerves, and it will help create the motor part of that for salivary glands. The esophagus, do you remember? I remember being surprised. There's certain things you're just surprised about in anatomy, other than actually anatomy itself, other than Dr. McNeil, is the esophagus. I remember just being really kind of wowed by the esophagus. I don't know if you remember your first esophagus. But I just was like, oh, that's not what I expected. It's not patent. I guess I sort of thought that the esophagus was patent, like your trachea. It makes sense that your trachea has these rings and remains patent at all time, but if the esophagus isn't swallowing a bolus, it's kind of snapped shut, really, and I just remember being really surprised by that. But anyway, it's a muscular tube, it's collapsed. It pierces the diaphragm. You have this gastroesophageal sphincter. We all really care about that sphincter, especially Americans, joining the stomach. And you see this lovely ergonomic architecture here. It is deep to the trachea, and you have the aortic arch kind of beautifully curving around it. And so it is quite lovely there, I think, with the way that all that architecture is. I have a soft spot for the aortic arch. In the mucosa, you have, or in the layers in the esophagus, so here's where we look more specifically at those layers. The mucosa itself is stratified squamous epithelium. Any changes in that epithelium then become something that's abnormal and can lead to carcinoma. So you'll see that there is squamous carcinoma and there are adenocarcinomas in the esophagus. But it is a stratified squamous epithelium, and when you want something to be durable, you have squamous epithelium, so that makes sense that would be there. There are esophageal glands, which are secreting mucus, and then ruga, or rugal folds, which we see a lot of the time for some sort of thing that's able to collapse and expand, which is what you want the esophagus to be able to do. So you see that in this state, without food going through it, it has a very narrow lumen. The muscularis layer, or where the muscles are, that proximal 1/3 is skeletal muscle, so under voluntary control. And I think this is just one of those another lovely thing that we do, because really your GI tract is exterior for the most part. It's open to the outside. And so there's this transition along the way, kind of like that respiratory tract where you have a transition from something really just simple and mechanical to very intimate and personal, nothing should be in there kind of thing. And it's kind of like that, I think, along the length of the esophagus. You see this change from being able to voluntarily swallow, super important, to the point where involuntary or smooth muscle just takes over. So those peristaltic movements take over. That enteric nervous system guides that myocentric kind of movement. And so the distal third is smooth muscle, so it's under involuntary control. And there's a mixture of muscle along that middle 1/3. So I think that's kind of interesting when you can have control over swallowing to a certain point, and then you know you kind of lose that control. I think. In the stomach, the function of the stomach is to serve as a tank, which will receive the meal and kind of shut down the sphincters on either end and just squish for a long time. Up to 2-3 hours is pretty normal. And so what you're doing is you're having a physical breakdown of food, a mixture of food with gastric acid and gastric juices, and a conversion of the meal to something called chyme, which is now a very liquefied version of that meal. You've seen it when you vomited. And depending on how long the food was in the stomach has a lot to do with how long that, have you thrown up meatballs lately? It just becomes ground meat. And then if it were in your stomach longer, it would just, you know. So I think that's something interesting to think about next time you vomit. Good talk. The esophagus is entering the stomach. You have the fundus, that kind of expanded portion that's a bit superior to where the esophagus enters. The cardiac region is there near the esophageal entrance. The lesser and greater curvatures, you remember the body, the pylorus, which is near the duodenum, and the pyloric sphincter. Oh, joy, I don't know why I didn't feel good today, because I get to say sphincter so many times. I should have remembered that going in, you know. Just put that on my list of things that makes me feel better, you know, socks. Functioning sphincters, use of the word sphincter, it's a short list, but it's a good life. It's a full life, sir. What are you there? Are you like Mr. Two Computer now, trying to one-up everybody? It's happening, and it's happening. The layers, there's a muscularis layer, as you would expect, submucosa, submucosa, muscularis, and serosa, like everywhere else. Pointing out that this muscularis layer, throughout the GI tract, the muscularis layer would have a circumferential or circular kind of muscle around that tube, and then a longitudinal sort of muscle along the length of the tube. And in the case of the stomach, there is an additional layer, an oblique layer, so you've got something running in all three directions right there, and that really helps the squishing to create chyme. So you see those all laid out there. Again, you have the rugal folds, which allow for expansion. So you're at about 1 cup, and you can go to something like a 4 cup. Did you ever watch My 600-Pound Life? Fascinated with that. So fascinated with just eating, and just fascinated with the psyche of eating disorders generally, because it's different than alcoholism. You literally can live without alcohol. I promise that's true. But you cannot live without food. And so, gosh, if food is your enemy, in a sense then, or that thing that you have your under or over nutrition about, then it's just, you know, quite a misery. You all know people who experience that, and you probably have at some point in your life, but anyway. So in that, they're all going in for these gastric surgeries, from bands to the bypass and all of this stuff, and reducing that size of that tank and all that implies. So anyway, the stomach layer is mucosa, simple columnar epithelium, and we really see columnar epithelium for a long time now throughout the gastrointestinal tract. There are surface mucus cells, which will be secreting mucus, and you have gastric glands, which will become a bit of a complex sort of arrangement that opens to gastric pits. So we'll look at that gastric gland because there's a variety. It's a heterogeneous group of cells that form the gastric gland. The gastric gland will be producing gastric juice, and that will have a lot of stuff in it, and so we'll look at that. specifically. So there is your gastric glands, and then the rest of the layers there that you see. So just remember that all those layers are present in all the organs. Specifically gastric glands. So let's look at the various cells. So you have this gastric gland, you have the pit, you have the neck or isthmus of that gland, and then you have some cells that are arranged in kind of a couple of sacs or a sac-like sort of structure. That's the gastric gland. So in the neck are the mucous neck cells, and there you have cells that produce mucus. That's going to be super protective. Here the mucus is not so much working on the bolus of food like you had in the mouth, but it's really performing kind of a protective layer against that gastric surface cells themselves. There's also a stem cell population which will give rise to, and we've seen this in every single organ system, which makes sense, that would give rise to new cells. The overturn is very rapid in the gastrointestinal tract, and so you know that because when you have people who are taking, especially like chemotherapeutic drugs, which are active against actively mitotic cells, that should really get the cancer cells, but it's tough on the gut. And so one of the first places everybody has symptoms is there in those cells that are being reproduced very quickly, so they have intestinal symptoms. But 3 to 6 days-ish is about the cell turnover, because that's a hard environment, the gastrointestinal tract. You have parietal cells as part of the gastric gland. Parietal cells will produce HCl, stomach acid. So your gastric juice is about a pH 2-ish. That's super acidic. You remember the blood's at 7.35 to 7.45. pH 2, straight up acid. That's pretty tough. But what it does do is it's really good at just physically reducing food into something very watery and broken down, and kind of just physically reducing foodstuffs, so then you can have active enzyme activity on that. You wouldn't get all the way into that meatball, just around the side of it. The parietal cells are producing HCl in response to histamine, and gastrin, and we'll look at those as we go along. So that's well named. Gastrin is going to be a hormone that enhances gastric acid secretion from parietal cells. Also, parietal cells will make intrinsic factor, and when that is not made, then you have pernicious anemia or vitamin D anemia. So you went through the anemias in hematology. Oh joy, the anemias. Remember pernicious anemia? That was a vitamin B12 deficiency because of the lack of intrinsic factor. So anyway, that comes from parietal cells. Another cell in the gastric gland will be chief cells. Chief cells will be producing pepsinogens. Those are going to be proteases, and they're generally, like most of the time, enzymes are going to be secreted from cells in especially proteinase or protease enzymes will be secreted from a cell in a pro-hormone kind of state, or I shouldn't say that, pro-enzyme sort of state. And then, so in this case, pepsinogen in low pH gets converted to pepsin, and then pepsin can go and start to eat up proteins in the ingested foodstuffs. Also lipase. So chief cells are making enzymes. So enzymatic activity is occurring in the salivary glands by the action of amylase, and then in the stomach by the action of, for one thing, for example, pepsin, and also lipases, which will be doing the lipolysis, which is to cleave up triglycerides. Excuse me, that are in the diet. Let me go back and just show you, this is a nice little picture of how stomach acid actually gets produced. And so it's water, it's ionized in the cell to a proton and OH. Bicarbonate gets made, and that can be put in the blood, chloride is taken in from the blood, and then so the cell is secreting protons and chlorides, and those will form hydrogen chloride out extracellularly, which just makes sense that you wouldn't be necessarily making acid itself inside the cell, because that would be destructive to the cell. So the cell is secreting the components, and then it's forming outside, or in the lumen of that, of the stomach itself. Just to point that out. Parietal cell makes HCl. Chief cells, enzymes. And then there are enteroendocrine cells throughout this throughout the stomach and the small intestine. And so these are the cells that are producing hormones. They're hormone cells of the GI tract, releasing hormones. In the case of the gastric gland, these are called G cells, which is also handy, and they're producing gastrin. Gastrin is a hormone produced by the G cell that acts on the parietal cell to produce acid. So there's a few important hormones along the way, and I just like to, we'll just put them here. Produced by G cells. G cells are in the gastric gland. What cells do they, what's the target of the gastrin? The target is parietal cell. And what does the parietal cell do? Is secrete HCl. So increased stomach acid. So back on the parietal cell, I said it was enhanced, that gastric acid production was enhanced by gastrin, and also histamine. There's a histamine receptor on those. It's called an H2 receptor, and so there's a whole series of drugs that are H2 blockers. And then there's a whole series of drugs that are proton pump inhibitors that would inhibit the production of release of protons from parietal cells. So this is where you target anti-acid activity. So, okay, that's gastrin. Gastrin is going to be a hormone. So looking at that word, do you know if it is made from protein or do you know if it's made from cholesterol? Oh, dear God. Does anyone have a fork? I can just stick it right in my forehead. God, I got some in my purse. So hormones that come from cholesterol will have sterol kind of names: testosterone, estrogen, aldosterone. So the ones that come from protein often have names that end in N. So insulin was an example of a protein hormone. There's glucagon. There's another example that doesn't end in that. So anyway, just so you know, those typically, the protein hormones typically last or circulate in the blood a little less time. And so what's interesting about these enteroendocrine cells is this is a hormone, this isn't a paracrine activity. The activity is actually paracrine or nearby, but that hormone is exiting the area to surrounding capillary beds, circulating, and then having an activity back on the stomach. So that says probably it's going to have activity elsewhere on the gut as well, and we'll certainly see that. So anyway, we'll add to that function. Gastric gland, gastrin, G cell. Also ECL cells, enterochromaffin-like cells. Okay, do you remember we used the word chromaffin at one point during this, this deal? Do you remember which gland makes chromaffin? Don't you hate it when you have to remember stuff? Adrenal medulla makes chromaffin. Damn, sometimes you got one. So you left one after this weekend. Chromaffin cells made catecholamines in the adrenal medulla. Name a catecholamine. Ah, I hate her. Name a catecholamine. What? Oh, well, technically I don't have the ability to remember that answer. But for sure, what does the adrenal gland make? Like adrenaline? So acetylcholine is made from choline and acetyl. So no, it is not catecholamine because it's not made from tyrosine. Did that just happen? Yeah, it did. So these are enterochromaffin-like cells, so they kind of seem a bit like those chromaffin cells of the adrenal medulla. Just to throw this in there, do you remember what the cortex made? Adrenal cortex made? Corticosteroids, mineralocorticoids, and maybe corticoid type of hormones. So anyway, those were made from bad cholesterol. Okay. So the enterochromaffin-like cells are stimulated by gastrin. Oh, that does more than one thing. And it will stimulate the release of histamine from other cells in the gut. And so what did histamine do? It also acted to increase acid production. So that's kind of cute. So the target will also be ECL cells to stimulate histamine production, which also will go back and have a positive effect here. So there you go. That will inadvertently then stimulate HCl secretion. So the stomach is about amping up the stomach. Do we know that acid production gets amped up? We do know that. And isn't it interesting that those are kind of chromaffin-like cells? So histamine is an amine, so it's not really a catecholamine because that's epinephrine, norepinephrine, and dopamine. But histamine is an amine, so that's why those cells have a similarity to each other. And you care a lot, I can tell. So, food, 3 phases to eating. There's see a cupcake, desire the cupcake, eat the cupcake. Try to talk yourself out of a second cupcake. But there are 3 parts to it. There's a cephalic phase where you're eating in your head before you're eating. Then there's the gastric phase, and then there's an intestinal phase. So these all have to happen because what happens is your stomach is going to have to function a little bit differently than the intestinal tract because the stomach is prepping everything for the absorption of the intestinal tract. So one thing you have to do is, while the stomach is acting, you need the intestinal tract to act to move stuff on down the way because you're getting ready to have more come through. So it's going to have a function on transit time throughout the whole system. And so you got to get that all ready. So the cephalic phase is that sight, smell, thought of food. And we certainly have a whole pleasure center around all of that, don't we? You know, and stimulation of probably serotonin or something. And it's just something that continues to activate that pleasure center. And there should be a point where we feel fullness and we stop. But that brain part of it is that you can overcome any sense of too many chips and salsa. And so it's just really interesting. And also that you prep what it's going to taste like. Why do we have desires for foods and stuff like that? You're in the mood for, you know, and all that. So we have that luxury because we have so many choices. But you know, if you've ever thought, oh, okay, I'm going to take a drink, it's Coke, and then it's tea. Why does that have such a drastically different effect on how, you know, because it's that anticipatory thing, so I think it's pretty interesting. So there's receptor activity to the hypothalamus, which is really kind of setting the pace for so much, output to the medulla via which parasympathetic division nerve would be servicing the gastrointestinal tract. If that wasn't written up there, you could eventually come up with it. Vagus. When in doubt, vagus. When in doubt, below the mouth, vagus. It's also, oh wow, that just was a weird sentence. When in doubt, below the mouth, vagus. That could be their new slogan. What happens below the mouth stays in Vegas. Just no, it's not. That's not working. Where was that? Derailed. Vagus. Okay, so parasympathetic division is GI. It's rest and digest, so we're really going to see that taking over throughout this particular section. Stimulating gastric gland secretion. So what were some of those things? Mucus from goblet cells or mucus cells, HCl from parietal cells, enzymes from, example, the chief cells, gastrin from the G cells, and histamine from ECL cells. So all those cells that are there, and then they get turned on. They start their function. So you can get ready for food. Then once food is there, you have to have some relaxation. You have to have the ability of the stomach to expand, and then the feedback that it's time to stop. But what you need to do then is start the muscular part of that, so that you can have the function of the churning for chyme production. So food is entering the stomach. The distension will cause some secretory activity that enhances that, not just cephalic part, but localized distension will enhance the effects of those gastric glands. And then also the stimulation of the enteric nervous system. We'll talk about this a bit more later, but at the end of the autonomic nervous system neurology lecture, I said there's another autonomic or involuntary nervous system that's very huge and exists in the gut, and that we get to it. We're going to get to it, but it's that enteric nervous system. There is a higher input to it, but it actually has a lot of its own pacing, so it can instruct muscular movement, and also glandular secretion, and also vasomotor activity as well. So there's a couple of layers of it. One of it exists in the muscularis layer, and it will direct muscular activity of the smooth muscle of the gut. So that's the enteric nervous system. And then also the vagal reflex is just that when there's sort of physical distension, you'll get the parasympathetic gland feedback and causing more activity. So the presence of food stimulates activity of the stomach. It's pretty much a positive feedback kind of thing. And then the gastrin and histamine release will increase the HCl, and everything can get cooking. The other part, there are three parts to the functional anatomy of the gastrointestinal tract. That was the cephalic phase, the gastric phase, and then there's the intestinal phase. And it really has to get going. As soon as the stomach begins to drip, it's made chyme, and then it will begin to drip chyme in just like a dripping faucet fashion through that pyloric sphincter into the duodenum. So you want that to happen kind of slowly, but you also need to prepare that food for transit along the line. Or chyme, I shouldn't call it food anymore. But the intestinal secretions have to happen. So a lot of what's going to happen to that food is it needs to be completely enzymatically digested so that absorption can occur. Intestine is going to be enzymatic digestion and absorption. And so you have to get all those things that you need there. So pancreatic secretions, liver or bile secretion, and also then the intestinal secretions. I don't know if I just said that. I think I meant to. So liver, pancreas, and intestinal secretions should all be there when chyme begins to arrive. That's the intestinal phase. I don't know if what I just said made any sense. That will inhibit gastric activity. So you don't want the stomach really squeezing and blowing chyme out into the duodenum, because you really want that to be a nice slow drip so that you can sort through and get everything you need for absorption, for maximum absorption of that bolus of food. So, think about the function of the intestinal tract if you didn't have a constant supply of food, keeping it that way. If we were really just eating a big meal daily or something like that, man, you really have to maximize all the absorbed nutrients out of it. And that's the way the system is set up. And so the length of our dentition, our stomach, the size of our stomach, the unidirectional flow, and the length of the intestinal tract tells us that the human body is meant to eat a variety of foods, from meats to vegetable type foods or so. That's just what we're set up to do. We don't have to do that, obviously, but we need all the components anyway, no matter where it comes from. So that's a fact. intestinal phase, secretions occur, inhibit gastric activity, because you also need to stop HCl production because you're done. You're done there. So that this is a very coordinated effort, as you might expect. Gastric activity is inhibited by hormonal feedback from some intestinal hormones. So that's lovely. So once food starts to arrive in the intestine, we can feed back and tell the stomach to kind of stop. And then also by vagal feedback, you can have an inhibitory or a decrease in vagal stimulation of gastric movement. So we'll look at secretin and GIP as we get there. The next thing then is the small intestine. I like this old picture. Our intestine is like 6 feet long because it has tone, but a cadaver intestine is something like 20 feet long or something like that. And so you see this guy. What is that stupid movie with Mel Gibson? I don't know why I just thought of it.
Braveheart.
Yes. I believe they eviscerate him in the movie. I've never seen it because I've never liked Mel Gibson, but anyway, that's just one of those deliciously awful things to imagine. Isn't it? People, come on, you watch gross stuff, right? You do. Dr. Pimple Popper, right? No, but aren't we a little fascinated? And if they don't show everything, isn't that more fascinating? Okay. The duodenum is the early part of the small intestine. See how nice this is? Just some nice names that you already know. And duodenum means 12 finger widths. So if that were 12 men's fingers, then that'd be about 10 or 12 inches, something like that. The jejunum and ileum. So ileum is at the end. The mesentery, of course, deliciously wraps and suspends everything. And you have the vein, arteries, and nerves kind of suspended and entering via that mesentery as well. And all of it is framed by the large intestine, or colon. The duodenum is really going to set the pace. And so as whatever is happening in the intestinal tract, the most of it is happening earlier. And so the greatest amount of enzymatic digestion and absorption as well. I mean, so it's happening along the way, but you get your best results early on because that's where time is coming in. What else could I say about this right now? Anyone interested in general surgery? All of that, it's just so different than orthopedic surgery, isn't that right? It's just like orthopedic surgery. It's so they're such carpenters and everything's so clean and everything is just. And then in general surgery, it's just like you can just hear stuff. Or in obstetrical surgery, there's just a and then you step over and you're just like, oh, that's so different. That's kind of messy. That seems messy. But anyway, just so interesting when you go through all these rotations, just like you come away with, yeah, this one idea, and then you're like, oh, that just seems like a mess. Like you want to go, I mean, you know where you are, right? You know, like a neurosurgeon makes a really small incision, and the smaller the incision, that's why they pride themselves on the tinier spot you can operate in. Well, splat. And so, it's just interesting. I love the small intestine. I love the small intestine so very much. There are modifications for absorption of the small intestine. So the majority of your enzymatic degradation of food is occurring really in the small intestine. So you've gotten stuff from, first it was a pie, and then it became chyme, and now you want to get down to every individual fat and protein getting to its components. And so a great majority of that is happening in the small intestine, which makes sense because when those components happen, you want them to be absorbed into the small intestinal cells and end up in the blood. Because this is what we're trying to get is nutrition, so that can get distributed to every cell. And so you're just trying to get sugars, amino acids, gosh, there's some other stuff. What are they? Like vitamins, electrolytes, lipids, and distribute that around. Also nucleic acids as well. So we're really just trying to get those components distributed to cells. And so you have to have some certain modifications to increase absorption. So one thing is you have to get stuff to move along the digestive tract, but you also want some opportunity to slow things down and really mix it up, and a lot of surface area into interdigitating into that chyme. And so there's a lot of modifications to increase surface area. So plica circulares they're just folds. This picture here in the very kind of top corner, so you see mesentery and you just see sort of growth structure of the tube. So look at these circular folds. And that's just going to create some sort of large divisions along the way, which will actually help sloshing and slowing and mixing occur. That's one thing. So those are some folds to slow the propulsion. Then there are villi, and so I know you know villi. I think that's something you start looking at really early on in sort of the biologies. And those are the finger-like mucosal projections, which will increase the surface area. And so I think we always think of them as being like, finger-like, because that's as always, there are little appendages, cellular, or it's mucosal appendages. But look, they're really kind of flat and what's a disc-like, really. So in this picture, you see villi. Those are duodenal villi. The villi along the length of the gastrointestinal tract kind of changes, and they do become smaller and thinner, but you have a lot of surface area there. And so I love that. I love that picture. So think of a towel naph. All those loops in the towel. Those are the villi. So that's going to really, and that's exactly for absorptive surface. And so you're having all of those projections there. And that's columnar epithelium in the small intestine. Also the lacteal. So I should also put, within each villus, if you could just look at a cross-section of villus, it's epithelial cells lining all along that. And then interdigitated or invaginated into that will be capillary, because that makes sense. Remember around the alveoli in the lung, you had this capillary net there because you were trying to have a great surface area for receiving oxygen and delivering CO2. So here in the villus, you have a capillary projected into that, and running through that also will be a lacteal, which is a lymphoid kind of. You don't say capillary because a capillary would be a fenestration between two vessels, but a projection of a lymphoid vessel is the lacteal. And that's because we have to deal with fats. So you're eating, and you're going to have fats, and they can't just easily go directly into the bloodstream because they're going to be in sort of some big chunks called chylomicrons. I know that you looked at all of these, the LDLs and the VLDLs and all that. Chylomicrons are being produced in the intestinal tract, and they'll go directly into lacteal, which means into the lymph system. Then they'll end up getting processed by the liver. So where you have a big bunch of lipids coming in, which would be the small intestine, you have to have a special way of receiving them, and that's via the lacteal. And it would be more appropriate for me to also have said that each villus has a capillary tuft as well. So water-soluble stuff will be absorbed there. Fat-soluble stuff will go into the lacteal. Let's take a little 5-minute breaky break and talk about the brush order.